they're analyzing our every motion, right? And this is an interesting, for a lot of careers, but especially medicine, automation and AI is actually a very interesting subject matter because, for example, we already know that in the diagnostic realm, the artificial intelligences are actually better than the humans in a lot of things. For example, a machine can identify a skin cancer based on pictures better than the dermatologist can, right? They can identify abnormalities on radiology, on CTs and chest x-rays better than a radiologist can. Because if you think about it, as a surgeon, when making a decision, I rely on my expertise, the expertise of my mentor and my colleagues, right? The same thing for a dermatologist and a radiologist. They have their breadth of experience, but a robot has the access, or the AI has the access to that information from all over the world, right? They've studied literally every single picture of a melanoma, so they know exactly what it looks like. So we're reaching that stage right now. For robotics, as far as surgery, as I said earlier, there's idea that the simple tasks can be automated. So, like I said, there's a picture of one, there's a video of one where it makes an incision on the pig fascia, and you press a button, and it just does this, and closes it, because that task is simple enough to be automated. They're studying our motion. What they're doing is they're taking all the surgeons doing all this information and saying, well, this surgeon does this part of the surgery well. He's very efficient at dissecting out X organ. Incorporate that to this surgeon is very good at closing this. So and you can put all that together and actually find the optimal moves to make the most efficient surgery. I think we're a little ways off in accepting a robot surgeon. I think when we accept a fatality from a autonomous car, and we say, well, that's what we expect. Overall, the numbers are better, but this one, a pedestrian got killed. At that stage, we'll maybe be ready to accept a robot surgeon, but until then, we're not. So hopefully not in my career. Hopefully in a few more years, but that's here.
So are they just kind of adding to that? Have they been trying to develop what would they incorporate in terms of fail safes to avoid accidents with them?
So that protocol has not been written yet, and it's a very good question because for a time there will definitely have to be surgeons on standby at all times to do it. Eventually, don't think these executives of this company they want to eventually, right? Because if you can do a surgery and you walk into a box and take out your gallbladder, you walk out. That's the dream, right? Until then, though, there's going to be, and right now the protocols we're at such an early stage, those protocols aren't even being developed yet. Everything's being tested on, obviously pigs.
Okay, so do you see a day when there would not be a need for a surgeon to program a machine or an AI or show an AI how to work?
Well, it all depends on access, right? For example, in this country, in a place like this, we have access to the highest level of technology. And yes, the patients here could probably go without seeing a surgeon, right? You have an AI that tells you have gallbladder disease, and you have an autonomous robot that can do it. It's in other parts of the world, right? And that's where there's always going to be a room for that, right? Go ahead.
Speaking to your point about other parts of the world, is Da Vinci the only one that's licensed in the U.S.?
In the U.S. currently, yes. There are two in the wings. So Google is working on a robot right now with one of the industry players. Johnson & Johnson is also working on a robot. There was one out of Canada that was very close, but it had some setbacks. So there's a couple of them coming right now.
Are they in active use elsewhere in the world?
The other ones, there are a couple that are, to be honest, those two I don't know if they're in active use. There are other robotic companies in Europe and Asia that are being used that we don't have over here. But the J&J robot and the Google robot, I'm not sure if they're using it. I know they're testing it in certain places, but as far as widespread use, I'm not aware.
Excuse me, I'm always amazed at the clarity of the images. Are the surgical sites irrigated with ringer, or is they inflated? I mean, it's like.
And most of this is without any irrigation whatsoever. This is how the body looks when under insufflation, absolutely. I mean, obviously if we get into a bloody field, we wash it and that sort of thing, but most of the time we don't have to.
So the robotic system is collecting data on the movement of surgeon's hand. So in a way, they're going to use that data in some kind of an expert system to automate it down the road?
Yes, that's the idea. None of the guys will admit that, but we all signed these disclaimers saying they're going to study our data, and I honestly I believe that's what it's for.
If they have access to your data, they ought to give you some IP revenue down the road.
That would be nice. That would be nice.
If you're going to use my performance data,
Sure.
then I need to have ownership stake.
Yeah.
If it was on Sam's gallbladder, he wants a cut.
He wants to it's the sort of thing where, again, they're able to draw from the experiences of surgeons around the world and again, isolate who's doing it the best and piece it together.
Is there something to be said about the feel? I've heard surgeons say that they can feel certain things with their hands when they're doing an open operation and things like that. You don't have that when you're doing it with a robot.
Absolutely, that's a great question. That's a part I didn't include in the talk, but the early robots have no tactile feedback, right? They have literally none. You can push that thing and you'll push through the tissues, it'll push through bone if you let it, right? It has a certain burst strength, obviously it doesn't. But you can do actually catastrophic damage if you're not careful. So you're relying on visual cues. So when you stretch a tissue out, in real time you'd feel it, you know that it can't go, but you're watching the tissue stretch and say, well, that's all it can take, right? Even with laparoscopy, there is that tactile feedback through the instruments. So, for example, I don't do any gallbladder surgery robotically, right? Because I prefer the tactile feedback of the biliary tree when I dissect it, especially in acute infected operations. I think it works better. But the next generation of robots is going to have some tactile feedback. You'll start feeling, much like the game controllers, you can feel that they'll start incorporating that as well. But that's the next step. Yeah, that haptic technology they call it. Next generation robot has some element, some basic element. I think every 3 or 4 years they're releasing another generation, so it's going to be exponential. And then when the competitors hit the market, that's when I think we'll see a lot of real change, because right now, each machine costs about $2 to $3 million. Go ahead. As far as the cost? Yeah, it's a tremendous cost,
I'm saying 1.5.
You're saying 1. So 1.5 is the super discounted rate that they quote. It ends up being about 3. For the. Yeah. You said 1.5. You might have found that on some of the industry pages, but for all practical purposes, for the accessories, the upkeep, and the other thing is, don't forget the service contracts, right? Every year, so it adds up to about between $2 to $3 million per robot. Laparoscopic surgery is not free, right? Laparoscopic equipment costs money, so the incremental cost is there. But once we see more players in the industry, that price will drop dramatically. So.
What's the price of 1 day in the hospital versus 6?
Exactly, and then you have to find that curve. And right now, the advantage over laparoscopy is we're finding more and more. Like, for example, and we don't have to go too much detail into this, but we have a hernia center of excellence at Thompson where we almost exclusively do robotic hernias. And as I was saying before, I did a lot of laparoscopic hernias prior to that. And that actually, from open to laparoscopic, the jump was dramatic. But we're finding now from laparoscopic to robotic, because of the ease of use, the dexterity that's allowed, the precision of the surgery, we're finding less pain, we're finding less narcotic requirement, and that's a big deal in this day and age. Our inguinal hernia rate for narcotic use used to be about 30, 40%, now it's 2%. So literally everybody goes home on Tylenol, ibuprofen, and ice. And very, very few get anything more than that, and the vast, vast majority don't need that. That's something we couldn't do laparoscopically. So you talk about those incremental costs, they start adding up. So. Other questions? Okay. We have a whole bunch of slides about our experience at Thompson, but I think at this point, I think if there's any other questions, I'd like to talk more. You guys are a very, very interesting audience.
Sorry.
No, feel free.
This is kind of a out of the blue question, but do you see any advantage to low or no gravity surgery?
You're talking about doing it in space. That's a question that, like we talked about, originally this was developed, this idea that a surgeon was going to be here and we're going to operate on a moon base. It might be interesting because with insufflation, when the organ start floating, it might actually decrease the the hands you need to retract and that sort of thing. As such, it'll probably be more of a hassle because we're so used to gravity-based surgery, but it'll be interesting. And that's the thing with these kind of surgeries is with the technology advancing so quickly, we're discovering surgeries that we wouldn't do otherwise. And I think in 10 years we might be laughing at these slides because we wouldn't do any of this way. So, and that's a very exciting thing about this era. Yes, sir.
I can't keep my cell phone to maintain a good strong signal. How are they ensuring that connection?
Sure. So, I think with that Lindbergh operation, I'm not sure how they did. I think they ran through fiber optics. I think it's a fiber optic transatlantically, right? For most of these, it occurs in the next one. There's physically a large cord. We're not talking about space surgery. Obviously, if we're talking about that, it's going to be. And that was an initial thought of it is remote surgery. But in practice, that's become less and less ideal, right? So it's still faster just to get somebody to a surgeon rather than set up a robot and that kind of thing, as of now. So.
Does everybody here know what DARPA stands for? You mentioned DARPA having an interest in this surgery, because I think that could be a lot of long-distance remote surgery.
And that's the Defense Department, and they funded this initially for this reason, because this was an obvious application. And that's actually what propelled Zeus and ASOP to heights that, and then eventually, Intuitive bought them up. Yeah, and that's actually the original. But that, as of now, hasn't panned out quite yet. We're still working on it. They did a surgery at one of the NASA bases undersea. They did a remote surgery that way in 2004, to good effect. But, largely, it's still, at this day and age, better just to get the person to an actual surgeon.
Does it work as well for trauma surgery as it does for implant surgery?
So that's a great question. So the answer is no, right? At this point, minimally invasive surgery is elective surgery largely. Now, we do emergency, appendectomies, gallbladders, even emergency perforations. That a true trauma surgery, the risk is too high of a missed injury that a standard laparotomy, and that's the standard place for it right now. Is a big laparotomy is trauma surgery.
So that kind of rules out the
some of the military. Exactly. That's a good point there. Yeah. But if they have an isolated injury, perhaps they could do it. And they're, I think, largely thinking about a space population, maintaining, and people need appendectomies and that kind of thing, right? So.
I have a quick question.
Yeah.
Somebody who's in high school and is interested in surgery with robotics, do they have to finish being a doctor and then get into, or are the courses where they're intermingled? You can learn.
So you mean interested in surgical robotics?
Right. So is there courses that you start with surgical robotics, or do you have to become a doctor, become an MD? And then
Generally, you finish surgical training and then you train on the robot. It's basically an extension of laparoscopy. And the way to think of it is it's a very fancy tool, and it's the next step. Eventually like I said, we're going to have more and more of these kind of tools. But that's what it is, yeah. Oh, and on that note, if anybody would like to come and watch a robotic surgery, you're welcome to come. I operate 2 to 3 days a week, and we have full days, and anybody's welcome to come and watch. So
there is a glass window you can.
No, you just come in the room. The only thing is you just need a TB test from your primary care. We have high school students all the time come in, and anybody's welcome. So let us know. Dr. Stam can reach us. So.
Comment for the students in our IC Tech program. Sophomores are required to ask at least one good question, unless Alara donates her question to you. Okay.
Yes, sir.
You're saying eventually the human equation will be eliminated as far as the surgeon?
I think we're headed in that direction. Honestly, I don't know the time frame. I think we're hopefully looking at 20 to 30 years out, but the way technology is moving, the interesting thing about that visualization, right? For example, with a tumor, we get a 5 centimeter margin on a colon cancer because we know the data would suggest that is the margin at which the recurrence rate is the least, right? The safest margin at which the recurrence rate is least. We may find that with the robot with the enhanced visualization, we can see, well, maybe a 3 centimeter margin with a good perfusion is actually better. there's going to be a time when the robot sees better than us. And that's when I think we'll start to see. Because, for example, in head and neck surgery, where you don't have that much margin, if you can limit that and obviously avoid critical structures, that's where we're at.
Even as far as where you're saying the robot could be better than the surgeon, but it could be vice versa, the surgeon could be better than the robot.
Yeah, and at this point, it's just a fancy tool, right? We use it as an extension of ourselves, and obviously, there's no autonomous robot. Eventually, as the AI kicks in, as the techniques improve, as the visualization improves, it's going to be better than us at some point. There's going to be a curve, where it becomes better than us. And like I said, in some of the diagnostic fields, it's already there, right? It's just a matter of our infrastructure right now. Nobody trusts it. There are Google algorithms going on in the background. They've tested this even for primary care, where they can make it almost as if there's a human on the other line, right? And they can answer a lot of questions and get to a certain point, and then obviously it fails. But
Is this also considered like nanotechnology or?
well, nano would refer to on the cellular level, and that again, in parallel, that's happening as well, and that's more on the chemical side. We don't have robots small enough at this point, but again, the accesses are getting smaller. Eventually, there will be a rover-type robot. We're working on that experience where, one of the types of surgery that's happening, rather than going through the abdominal wall, it's what's called natural orifice surgery, NOTE surgery, where you literally go in with a scope, you put a hole in the stomach, you go into the abdominal cavity, do some surgery, and then seal up that hole in the stomach. So the big draw there is there's absolutely no incisions. Right now, we're at the stage where putting a hole in the stomach is sort of unnecessarily risky, where you can have a tiny belly button incision and do the same thing. So those kind of things are coming in parallel as well.
Has anyone put an ultrasonic head on the end of one of those probes to allow you to see into depth and not just on the surface?
So we do that commonly with endoscopy. We do put an ultrasound probe on that. There is no specific robotic attachment for it, but that's a good point. To certainly look at those kind of visualizations. Right now, what we do is we actually externally put an ultrasound probe and find it.